Okay, for those of you who have survived, it's been a long day, but I'll try to keep you awake. So this is actually one of my most favorite talks because this really is a new disease. And if you were to extrapolate in the United States, based on the data that I'm going to show you, there are about approximately 1.5 million people who have type 2 diabetes secondary to Cushing syndrome. And I can tell you when I started on this venture 2 years ago, I never would have believed this. So I had a very good friend of mine who's a professor of medicine at the University of California, San Diego, and he decided to give up his professorship to go work for a company called Corcept to actually look at what I thought was going to be a dead end. And he asked me, Ralph, what do you think is the incidence of Cushing syndrome and run-of-the-mill type 2 diabetes? And I said, oh, okay, maybe 1 or 2%. I can tell you that I didn't give up my job because I didn't think that this would be a successful outcome. But it turns out that this is actually a very, very common disorder. In fact, hyperglycemia secondary to hypercortisolism, it has been known for a long time. But in the United States, it really didn't get much publicity. But there have been studies that have been carried out in Brazil, in France, in Italy, in Denmark, where if you look at people who are poorly controlled, meaning they're on multiple oral agents and their A1C is above 7.5 to 8, you can see in this slide that the prevalence of hypercortisolism in this unique population of people who are poorly controlled is about 25%. And I have to say, I just was not very familiar what these data have been published in other countries. So what is typical Cushing syndrome? Everybody in this room, if this lady, this is Minnie G, this is from the original Harvey Cushing's publication in the Johns Hopkins Medical Bulletin in 1932. If this lady walked into your office, you'd immediately make the diagnosis of Cushing syndrome. You know, she has a puffy face, she has a buffalo hump, she has protuberant aberrant, she has stria, and if you asked her to get up from the chair because of the proximal muscle weakness, she would have difficulty doing this. So how many people like this have I seen in my entire practice as an endocrinologist? 4. So this is a very uncommon disease. But in fact, it turns out that Cushing syndrome is actually very common. But the patients don't look like Minnie G. So this is a typical patient. You would have many people who look like this in your practice, and you would never think that this person has Cushing's syndrome, but she does. So how are we going to recognize these people? Well, they have type 2 diabetes, so okay, lots of people have type 2 diabetes, but the DTC, difficult to control, is what I want to emphasize. They have hypertension. Well, 70 to 80%, you heard from Dr. Nielsen, of people with type 2 diabetes have hypertension. So what? The issue is that it's hypertension that's difficult to control, and they're usually on 2, 3 antihypertensive medications. They are overweight, but they particularly have central obesity. That's many of your diabetic patients. But from my standpoint, and in fact, when you heard the bone lecture, this was brought up. If you have a person who has type 2 diabetes and they're, you know, sort of middle age, and they present with osteoporosis or fracture, you really ought to be thinking about Cushing syndrome. So I've called this the big 4. And you need to now start to reprogram your thinking about whether you should be thinking about Cushing syndrome when you see someone with type 2 diabetes. So this is the big study, the first study that looked at this in a prospective way. It's called the Catalyst study. And Dr. Buse and I think, were the two key people along with the folks at Corcept who put together the study protocol. And what we wanted to know was, what is the prevalence of hypercortisolism? Of course, this is an American study, not an international study, in people who had difficult to control diabetes. So difficult to control diabetes meant your A1C was above 7.5. You had to be on greater than 3 antihypertensive medications to get into the study, or you could be on 2 antihyperglycemic and 2 antidepressive medications, or you could be on insulin and any one additional antihyperglycemic medication, or you could be on 2 antihyperglycemic drugs and have a micro or a macrovascular complication. So what we're really looking at is people with advanced diabetes who are difficult to control. So how do we make the diagnosis of Cushing syndrome? It's a very simple way. We do the 1 milligram dexamethasone suppression test. So at 11 o'clock the night before, they take the tablet, and they're going to come now and bring a blood sample the next morning. And on that blood sample, we're going to measure the plasma cortisol. And the new cut point that's now established by both the European and the American Diabetes Association for the cut point for cortisol is 1.8. But I can assure you, if I took anybody in this room and I gave you 1 milligram of dexamethasone, the next morning your cortisol level would be 0, okay? In the old days, we used to use a cut point of 5. And of course, we're never going to make the diagnosis because that was so high. Okay, so the new value is 1.8. The other thing that we're going to do is we're going to measure the dexamethasone. So we know whether the patient actually took the pill or not. And so in order to say that this is a valid test, the dexamethasone level had to be above 140. I'm going to show you the actual levels for cortisol and dexamethasone in a second. Then on a separate day, the patients came fasting, and we also measured the ACTH and the DHEAS, dihydroepiandrosterone sulfate value. So obviously, we want to make sure we're not dealing with pituitary or ectopic ACTH from the lung. If you have a high ACTH level, you should also be driving adrenal androgens, so you would also have a high DHEAS level. So what did we find? This was really quite shocking. It turned out that 24% of these people with difficult to control diabetes actually had Cushing syndrome. They had hypercortisolism as the cause of their disease. The Texas Diabetes Institute was one of the centers. We enlisted 33 patients as part of this study, and of the 33 patients, 14 of them turned out to have hypercortisolism. And quite frankly, I was embarrassed that these people are in our practice, sitting in front of us, and we hadn't even thought about this diagnosis, okay? Now, what was the cortisol level in these people? There were 252 who had a non-suppressible cortisol level, and the mean level was 3.5. So this was well above the value of 1.8. And you can see here the dexamethasone, the people really did take the dexamethasone. The level was 413. We used 140 as a cut point to say, yes, you took the tablet. The other thing that we did was an abdominal CT, and it turned out 1 in 3 had an adrenal adenoma, which meant that these people have a potentially curable disease. And we'll come back and talk more about this in some detail. So if I were to come back now, and I will add now this study, the Catalyst study, carried out in the United States, and you compare it to studies done in Brazil, Denmark, France, studies from Italy, which are not up here, you can see that this is pretty consistent. So whether you're in South America, North America, in Europe, We haven't looked at it, and I'm not sure that there are data that are available from China and Southeast Asia, but this is a very, very common problem in difficult to control diabetics, and as you're going to see, we actually have a pretty good treatment. So these are the data from the abdominal CT. 23% had a unilateral adrenal adenoma, so the endocrine surgeons would love you because this is actually a very easy surgical procedure for them. There are some people who had bilateral adenomas, some that had a little bit of hyperplasia, but 2/3 of the people actually really had nothing that was abnormal on the abdominal CT, which means that these people are going to require some sort of medical therapy in addition to treating the diabetes and what goes with it. Now, when we look at the cardiovascular risk factors, we're going to compare the people in yellow who suppressed, meaning their cortisol level the next morning was less than 1.8, to the people who had hypercortisolism, they're in orange. And if you look at a whole profile of cardiovascular risk factors, it's 33% versus 20%. It's statistically significant. If you look at established coronary artery disease, these people with hypercortisolism have an increased incidence of coronary artery disease. Atrial fibrillation was 3 times higher, and heart failure was about 6 times higher. So making the diagnosis of hypercortisolism in these people tells you you're not only dealing with diabetes, you're dealing with a cardiovascular disease. And you for sure need to intervene. Hopefully we picked them up earlier, but you're clearly going to have to be meticulous in terms of all of the cardiovascular risk factors. This is a summary of all of the medications that the people were on who screened in positive. And these people are sick. They have total body disease. So it's not that they're requiring antihypertensive medications. I told you that helped to get the people in. They're on multiple anti-hyperglycemic medications. They have a high incidence of microvascular complications. This is what I find now to be very interesting. These are the people who are difficult to control on those newer medications that Stefano just told you about, okay? So they were, the people with hypercortisolism were much, much more likely to be on SGLT2 inhibitors. The hazard ratio is 1.6. They were more likely to be on GLP-1 receptor agonists. And look at this guy here, tirzepatide. Remember, we talked a little bit yesterday about why do 5 to 10% of people do not respond to tirzepatide or Ozempic? There's no reason why anybody should not respond to tirzepatide. It's a phenomenal drug. So if you have someone who's on Mounjaro and they're not responding as you think, a light bulb should go off and say, oh, Dr. D told me I ought to be thinking about hypercortisolism. There's absolutely no reason why this drug should not lower your A1C and promote weight loss. And if it doesn't do that, you ought to be really thinking about hypercortisolism. But it's not just hypertension and diabetes. Look at this hypertriglyceridemia, 2.6 hazard ratio for people who are on fibrates. Analgesics, because hypercortisolism is associated with pain. Psychiatric medications. We all know if I treat you acutely with high-dose steroids, there's a psychosis that goes with that. And when I withdraw the steroids, there's a psychosis that goes in the opposite direction. These people are a little bit crazy. But they're not crazy. They have a reason for being crazy. It's the hypercortisolism. And they very commonly go from one doctor to the next doctor to the next doctor, and the doctors say, well, Mrs. Jones, you're just not taking these diabetes medications, or you're just not taking your blood pressure medications. They actually are taking their medications. The problem is they've just got a disease, hypercortisolism, which is making their medications not so effective. Now, that's part one of the course, the Catalyst trial. we wanted to know what was the prevalence in this high-risk population who are difficult to control. The second part is now, can we do something about it? And in fact, many, many years ago, mifepristone was approved by the Food and Drug Administration for treating hyperglycemia in people who had Cushing syndrome. So there's already a drug that's on the market. It was approved, I think, 2013 or so by the FDA. But at that time, it was approved for those people who look like Mini G, the lady with the puffy face and the shoulder hump and the striae and the abdominal protuberance. No one thought that we're going to have this kind of incidence of hypercortisolism in our typical run-of-the-mill patients. So there were 136 people who were enlisted into the study, and the starting dose of mifepristone is 300 milligrams per day, and docs were allowed to titrate up depending upon the response to 900 milligrams per day, but the most common dose was actually 300. And the people who are going to get placebo and treatment, they're matched for age, sex, race, weight, waist circumference, A1C, abnormal adrenal scan, so people who had an adenoma were equally divided into the treatment group with placebo and the mifepristone. And the endpoint in the study was A1C, but there were a number of secondary endpoints, particularly weight and waist circumference. So what happened in the follow-up of these people over the next 6 to 12 months? So here now, and this paper is just recently published in Diabetes Care. So the placebo-subtracted change in A1C is 1.32. And in the group that got the mifepristone, I'll show you in a second, it's about 1.5% drop, and the placebo is 0.15. So the placebo subtracted, it's about 1.3, okay? Here is now the change in weight. They lost 5.1 kilos, and the change in waist circumference is 5.1 centimeters, which is really quite remarkable. So this is the time-related change. The placebo is in yellow, and as I said, it was about a 0.15 drop. 1.47, 1.5 was the drop in A1C. And the first time we measured the A1C was 12 months, but I can tell you at 12 weeks. But I can tell you within 2 weeks, the glucose fasting glucose is already starting to change. Now, if we look at the change in body weight, you can see the change in body weight is delayed compared to the change in the A1C. So clearly, this early change in fasting glucose here cannot be explained by the change in body weight, okay? Inhibiting cortisol with the glucocorticoid receptor antagonist got direct effects to improve, and I'm going to take you through the effects in a second, to improve insulin sensitivity and beta cell function, and they're completely independent of the change in weight. Now, obviously, when you start to lose weight, that's an additional benefit in terms of glycemic control. Now, these data in terms of glucose control are very, very misleading, okay? So why are they misleading? Because all of these patients, remember, are on multiple agents, insulin or oral agents. So if we now compare what happened in the placebo to the mifepristone group, for fast-acting insulin, we decreased 30% of the people had a decrease in the fast-acting insulin. If we look at the long-acting insulin, almost 50% of the people had a decrease. And it wasn't like a mini decrease. These people were decreasing 10, 15 units per day. And sulfonyl decrease was also observed. So what we're seeing is about a 1.4%, 1.5% drop in A1C, despite the fact we're removing all of these medications. So if they may not, and the reason why they were removed, of course, because the patients were going to have a problem with hypoglycemia. Now, side effect profile, the typical type things, when you go through steroid withdrawal, fatigue, nausea, vomiting, peripheral edema, these are all things that are very well established with respect to steroid withdrawal. The most troublesome one was hypokalemia. So why does this happen? So once I block the glucocorticoid receptor with the mifepristone, I'm going to activate the hypothalamic pituitary axis, and the ACTH level is going to go up. So the ACTH level is going to increase the plasma cortisol level. So even though I'm making you, I'm blocking the effect of cortisol, I'm increasing still ACTH. So measuring the cortisol is not a good way, obviously, to look at what's happening with this drug. Now, cortisol and aldosterone, okay, they bind to the aldosterone receptor with the same affinity, okay? But cortisol is 100 times more prevalent in terms of the concentration in the bloodstream. So we have now this big increase in cortisol because ACTH is going up, and the cortisol is hitting the aldosterone receptor, and that's activating sodium-potassium exchange. So hypokalemia was very common. So now in my practice, when I start the mifepristone, because we've actually screened, and it's really shocking, we see 10,000 unduplicated patients. We have way over 50 patients already identified at the TDI, independently of this study. All of these people, we start them on spironolactone, 50 milligrams. At the same time, we start them on the mifepristone, and you can, in large part, prevent the hypokalemia. So how does hypercortisolism cause hyperglycemia? This slide you've seen many times before, so I'm going to focus on the three big problems that we have to deal with in diabetes. Insulin resistance in the liver, overproduction of glucose throughout sleeping hours, fasting, hyperglycemia. Insulin resistance in the muscle, you eat a meal, post-meal, postprandial hyperglycemia, and beta cell failure. So you haven't seen this slide before from me. You saw it from someone else who used it. But in order for insulin to act, you have to tyrosine phosphorylate these three tyrosine molecules. IRS1 will move to the cell surface. It'll interact with the insulin receptor, and you'll tyrosine the contiguous three phosphorylate the contiguous three tyrosine molecules, and then you activate PI3-AKT. I could add another half dozen molecules here, but I'm not going to do that. You just need to understand that you have to activate that insulin signaling pathway. If that happens, GLUT4 will move and insert in the cell membrane. It will, activation here, lead to an increase in glucose transport. Now, there are two metabolic pathways that the glucose can pursue. It can either be stored as glycogen, and the key actor here is glycogen synthase, or it can be converted to pyruvate, and then PDH will then increase flux into the Krebs cycle. You'll generate ATP. So what does cortisol do? And come on. There we go. Everything that I'm going to tell you today is in a review article that just appeared this month in Diabetes. The paper and the results are, again, my first name on them is in Diabetes Care. So when cortisol goes up, it binds to the glucocorticoid receptor, and the glucocorticoid receptor, when activated, inhibits multiple paths in this insulin signaling pathway. Then, of course, that's going to impair glucose transport in the cell. All the negative signs in red lines indicate inhibition. Now, independent of the insulin signaling pathway, cortisol blocks the activation of GLUT4. In addition, it has a powerful effect to block glycogen synthase, and it inhibits pyruvate dehydrogenase by activating PDK4. So it really doesn't make any difference where you look in the muscle cell. you're inhibiting every single pathway. So it shouldn't be surprising to you that cortisol is a powerful insulin-resistant provoking molecule. Now, in addition, remember I told you people with Cushing syndrome, they get proximal myopathy. And one of the tests we would do is we ask them to stand up from the chair. And they can't do that because they have proximal muscle wasting. So cortisol, it enhances protein degradation and inhibits protein synthesis, which on a net effect is going to lead to a decrease in muscle metabolism. In addition, it activates myostatin, okay? And myostatin inhibits muscle hypertrophy. This is the big thing that people are interested with GLP-1. We'd like to block myostatin so that when I give you the GLP-1, I can prevent the muscle wasting. Well, this is exactly the way cortisol causes muscle wasting. Now, in addition, at the level of the fat cell, cortisol stimulates lipolysis, releasing free fatty acids. Elevated FFA inhibit glucose transport, inhibit glycogen synthase, and they inhibit the insulin signaling pathway. All this molecular stuff, this is all work that we've done, published many, many years ago. It's all coming now back to fruition because this is exactly what cortisol's doing. It's doing exactly what we see in our diabetic patients. Okay, so now let's take a look at the liver. So I told you, you go to sleep at night, you're diabetic, your liver overproduces glucose. So you can produce glucose either from breakdown of glycogen or from the gluconeogenic pathway. And there are 3 gluconeogenic enzymes which are key: pyruvate carboxylase, PEPCK, and glucose-6-phosphatase. And where, when you're sleeping, does the glucose come from? About half from glycogen, half from gluconeogenesis. So you break down alanine and you convert alanine to pyruvate. This is the Cahill cycle. This was my mentor when I was a medical student at Harvard for 4 years. Or you break down glycogen to lactate and lactate to pyruvate. This is the Cori cycle. You all learned this in your medical student days. You passed the exam. I'm sure you forgot about it very quickly after that. So what does cortisol do? It breaks down protein, I just showed you. So you're going to release alanine. It breaks down glycogen, lactate. There's a glucocorticoid responsive element in pyruvate carboxylase gene, in the PEPCK gene, and the G6P gene. So you're going to activate at the molecular level all 3 of these genes. Now, what about the beta cell? Okay, so this is the normal mechanism by which we stimulate insulin secretion. Glucose goes up, it's transported into the cell, glucokinase activates it, and you generate ATP that closes the potassium channel, calcium comes into the cell, and you release insulin. And to the left, over here, we've talked about GLP-1 and GIP. This is a totally different system. This is the adenylate cyclase system, and it converts ATP to cyclic AMP, and it amplifies this system. Now, what do glucocorticoids do? Okay, they inhibit GLUT2 transport. They markedly inhibit glucokinase, and they inhibit multiple intracellular steps involved in the glucose-stimulated secretion. Now, at the level of GLP-1, I would say the data are actually very strong that they impair the ability of GLP-1 and GIP to stimulate insulin secretion. There's some data, I would say, somewhat weak, that you might also see a decrease in GLP-1 and GIP. But nonetheless, you can see multiple steps in which glucocorticoids inhibit insulin secretion. So this is kind of a summary of all that I've said. These drugs are at the level of the beta cell, impairing insulin secretion, causing insulin resistance in the muscle. They're driving gluconeogenesis. And if you read the paper, this is a whole new hypothesis of what's going on. So glucocorticoids disrupt the normal circadian rhythm, and they interfere with the normal way in which cortisol feeds back to inhibit ACTH. And when you disrupt that rhythm, what happens is that you can get insulin resistance. And there's evidence that insulin resistance disturbs the hypothalamic axis. And so you get into a reverberating circle where hypercortisolism causes insulin resistance and insulin resistance causes hypercortisolism. It's a hypothesis. You may want to read the paper, but I think it's an interesting hypothesis. Now, everybody knows the Banting lecture in 2008. I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. And over the years, someone's come up with number 9, number 10, number 11, but Dr. DeFronzo never changed the ominous octet. Now, we have 1.5 million people, if you extrapolate from the Catalyst study, in the United States who have hypercortisolism as the cause of their diabetes. So I think it's time to change the ominous octet. Those little stars are all of the places where cortisol is causing a problem. And it's basically affecting every one of the ominous octet. So I think it's ready now to call it the noxious 9. So if you read the article in Diabetes, that review paper, it is called now the noxious 9, and I've added hypercortisolism here. Now, the other problem that we have to deal with is when the cortisol level goes up, as I said, it's going to activate that mineralocorticoid receptor, and you're going to see hypertension. And hypertension is present in some 80% of our diabetic patients. And if you look at the people who develop this syndrome, you have elevation in both the systolic and the diastolic blood pressure, and I'm going to show you something quite dramatic in a few minutes. But the cardiovascular complications go up really quite dramatically, anywhere from 2.5 to 5-fold, depending upon which study you want to look at. It's one of the greatest risk factors you can have for having a myocardial infarction or a stroke. Now, there are a number of potential factors that have been involved and implicated in the development of hypertension with hypercortisolism. And I think the most important one is this one here, activation of the mineralocorticoid receptor. So as I said, because I'm blocking, these are partial, mifepristone is a partial antagonist of the glucocorticoid receptor. I'm going to activate the hypothalamic pituitary axis. ACTH going to go up when I treat these people. And so cortisol goes up. And as I mentioned to you, they have similar binding affinity to the mineralocorticoid receptor, okay? But cortisol is present in 100-fold greater concentration than aldosterone. And I believe this is the major mechanism of the hypertension. There are a number of other mechanisms that have been involved. There's not an increase in renin or in angiotensin, but there are actually very good studies that have shown that sensitivity to angiotensin is markedly potentiated by cortisol. There's also evidence that cortisol activates the sympathetic nervous system, and you can show using tritiated norepinephrine that norepinephrine turnover is increased. There are a number of vasodilators and vasoconstrictors that have been shown to be dysregulated. And if you really want to jack up your cortisol level, look at a diabetic who has obstructive sleep apnea. These people have amongst the highest levels of cortisol in the world. Their levels are so high that they're approaching what looks like mini-G and floored people with hypercortisolism. So you all know about sleep apnea. You all know it's associated with severe insulin resistance. And one of the important mechanisms here is actually hypercortisolism. So I have 2 slides before I give you the final message. So this is a meta-analysis by Petramala, in which he went through the literature and collected studies in people who had an adrenal adenoma, which is non-functioning. And you can see it's actually a fairly large sample size. So there are 421 people who had an adenoma. This is going to be the control group. And we're going to now follow these people up, and we're looking at cumulative survival for some 15 years. So I can treat these people, and then I'm going to look at the people who have a functioning adenoma. They are actually hypersecreting cortisol, okay? And I'm going to treat them for all of their risk factors. So I'm going to control their blood pressure, I'm control their dyslipidemia, et cetera. And you can see that, yes, compared to the non-functioning adenoma, they're at very high risk for progression, even though I'm doing my best to treat all the risk factors. Now, I'm going to take these same people who have a functioning adenoma, and I'm going to remove the adenoma. And look what happens to their survival. It's markedly improved. So what this is saying is that cortisol, and I'm giving this talk at the Heart and Diabetes meeting that's coming up, cortisol is an atherogenic molecule, okay? So even though you correct all of the risk factors as best you can, you still have an enormous decrease in survival. And this now shows a multitude of cardiovascular events. So it's MI, stroke, peripheral vascular disease, et cetera. So here's the non-functioning adenomina. They have the lowest incidence of these cardiovascular events. Here I'm managing them pharmacologically, but you can see their hazard ratio is still 2.5. And now here I remove the adenoma, and in fact I don't completely normalize things because there's been a lot of damage done before I go in and treat the adenoma, but I make a big impact. So the message should be pretty obvious, is that the sooner, particularly for that 1/3 of the people who have an adenoma, those are the people who should be going to the surgeon. So what about treatment options? Okay, number one, if they have an adenoma, and that's why if you make this diagnosis, if the dexamethasone suppression test is abnormal, okay, you need to take the next step and do the abdominal CT, okay? Adenoma should be removed. Of course, if you have pituitary, which is a very uncommon cause of Cushing syndrome, then you need to call the neurosurgeon in terms of removing the pituitary adenoma. Pharmacologic management of the comorbidities, of course you're going to do that, but it's not nearly as effective as if you can get rid of the cortisol itself. Now, this is the mifepristone is Korlym. This is already on the market, but the company has a new one in development. It's called relacorilant. So what is the benefit of relacorilant over mifepristone? And this is currently under review by the FDA. They're supposed to get a response by December 30th. Korlym also has some affinity for the progesterone receptor. And so in women, it can cause vaginal bleeding in fibrosis. This is a pure glucocorticoid receptor, so it doesn't have this adverse side effect. Now, in addition, for reasons that I'm not going to go into, relacorilant, although it's blocking the glucocorticoid receptor, does not cause hypokalemia. So that's another benefit. Now, there are some steroid agenesis inhibitors. Levokinocol, this is Recorlev that's on the market, Olisirosat, 11-hydroxybutyrate inhibitor. They're also available. The major thing you have to concern about here is they prolong the QT interval. And so in people with cardiac disease, that can be a problem. And if you block the 11-hydroxylase, it can also block testosterone. And the other thing is, because they're steroid inhibitors, okay, you actually can precipitate an Addisonian crisis, because I can drive your cortisol level to 0. With mifepristone or relacorilant, they're competitive inhibitors, okay? So if I block the glucocorticoid receptor competitively, there'll always be a reflex increase in ACTH. So you may get symptoms of steroid withdrawal. You may get headache, you may feel tired, etc., but you're never going to participate in Addisonian crisis. So I think, this is really a call to action. As physicians, I can tell you 2 years ago, I was totally unaware of this syndrome. And if you have a disease that's affecting about 25% of difficult to control diabetic patients, you really ought to be thinking about it, and you should be screening these people. So remember the big 4: difficult to control glucose, okay? Difficult to control hypertension, obesity, particularly central, and for sure, if someone presents with fractures or osteoporosis, this should be at the top of your list. Very easy diagnosis. Give them 1 milligram of dexamethasone. They come the next morning, you measure the cortisol level, and you measure the dexamethasone level, so you know they took the drug. The cutoff point is 1.8. Above that, they're in trouble. And I've just taken you through the medical and surgical management. So this is the last slide. You're probably all happy it's the last slide. You're all tired, ready for dinner, but